And we are live. Here we are. Welcome everyone from Journal of Cardiac Surgery, a new appointment of this live talk. A Saturday morning spent for around an hour talking about different topics in heart surgery. Today we have one of the topic of most of my interest, that is robotic cardiac surgery. And we have an incredible panelist made by very several incredible individuals. The idea behind this live talk is to take one of the articles published on Journal of Cardiac Surgery and discuss with a series of experts. We have decided to combine two papers for this month. And the two papers have been both about the learning curve in robotic cardiac surgery. The first paper is by Dr. William Patrick and Dr. Matthew Williams, and is titled The Learning Curve of Robotic Coronary Arterial Bypass Surgery, a report from the STS database. And the second paper, published still on Journal of Cardiac Surgery from Sahin Senai and Dr. Jem Hallan, is an analysis of the learning curve for robotic-assisted mitral valve repair. Today here I'm joined by Dr. Jem Hallan from Acıbadem University in Istanbul, Dr. Sahin Senai from the same university, who will present their paper. The paper on training in robotic coronary will be presented by Matthew Williams, I6 resident, William Patrick, I6 resident from UPenn, and Matthew Williams from Yale University. Dr. Williams, I made you younger, like 50 years younger, be back in training. We will discuss this paper with Dr. Sloan Guy from Thomas Jefferson University, Hussein Balki from University of Chicago, and Stephanie Meek from New York Presbyterian Weill Cornell. All incredible, successful robotic cardiac surgeons. And I'm here today with Earbuds Hamed from Yale University, my co-moderator and co-hosting in this session. And we have also the honor to have Thomas Salerno, editor-in-chief of Journal of Cardiac Surgery. So I will just start asking William Patrick to present his paper, and if you can give us a little bit like a very quick presentation of what is the paper, what did you guys learn, what did you find, and what was the follow-up. Please.
Thank you for the introduction, and thanks to JOCS and editors for hosting this discussion. It's really a pleasure to participate. Really important topic. Obviously, minimally invasive approaches can provide better and more satisfying outcomes for patients, more so than the analogous traditional approach. And truly, patient tolerance for the traditional approach, particularly when the outcomes are equal, is waning in light of that. And maybe even so when the outcomes are less known, the long-term outcomes. So we set about to study the topic of robotic-assisted coronary vascularization CABG. And we did so with the idea of looking at hard clinical endpoints. A lot's been written about sort of component-specific endpoints, looking at time to completion of certain tasks, placement of trocars, taking down a mammary. We wanted to look at actually those outcomes that matter to the patient and to programs as you're thinking about starting a program or keeping one open. And so we decided to look at the national experience through the STS database. And we looked at four main outcomes. I'll just have maybe advance to the next slide. And the methodology we used, it was to assign every case a surgeon did a case number, which is the specific number which along which that particular case fell in that surgeon's sequence. So if that was their 10th robotic case ever, that was 10 fifth robotic case ever. That sequence, that case got a 5, and then we analyze kind of along a column all the case sequence number 5s for all the surgeons in the STS database. And the 4 outcomes we looked at were approach conversion, which was on-planned approach conversion. That's a specific variable in the STS database, and reoperation for any reason during the index hospitalization. And then composite morbidity and mortality, that's also pre-specified by the STS. And then we looked at a composite endpoint of those 3 things. So you didn't have an approach conversion, a reoperation, or a major morbidity mortality, we call that a procedural success. And what you can see here is that there is a curve associated with each one of these outcomes. And the important thing, log odds is a little tricky to understand practically, but when you're looking at these curves, when the slope starts to approach 0, that means the rate of change in that particular outcome is stabilizing. It's almost getting like an odds ratio of 1 compared to the things to the left and to the right of it. And so you can see here that a lot of these outcomes, almost all of them, except for maybe reoperation, start to stabilize at around, 10 to 15 mark of cases performed. And so we then decided to break up our cohort into dichotomize them and look at, well, is this a real effect? Do surgeons who do 10 or less cases actually have slightly worse outcomes than maybe those who have done more than 10 or so cases? And so the next slide will show the results of that. So here are the same outcomes, but again, we just dichotomized based on what we learned from these curves at 10 cases. And you see the approach conversion for the experienced surgeon was about 7.7%, for the more experienced surgeon, 2.5%. Reoperation, 18.9% versus 10.8%. And then composite major morbidity and mortality was about 22 versus 13%. And then when you just make a composite endpoint of all those 3 things, not unsurprisingly, those who do more cases are more successful. And this was a univariate analysis, but we go on to show in the paper that for approach conversion and procedural success on a very rigorous multivariable analysis, that those remain to be true associations. And I want to emphasize here that this was not a study to really compare the effectiveness of robotic coronary to traditional approach. That this was not at all the appropriate design for that. This was to show just kind of the curve that one would go through to try to inform our guidelines as we try to move as a group and a society towards the future.
Thank you. Earbuds.
Thank you, Dr. Patrick. I will request Dr. Sanay if you are able to present the next paper on robotic mitral valve repair and the learning curve.
Yes, thank you very much. Hi, everyone. This is Şahin Şenay from Acıbadem University in Istanbul. I would like to discuss about one of our recent papers. It's basically focuses on the learning curve for robot-assisted mitral valve repair operations. We have been doing robotic operations since 2010. And previously, there has been an experience of minimally invasive mitral repairs and also some experience of catheter interventions. You can switch to the next slide, please.
Yes.
So basically, we try to investigate the first 60 consecutive patients for isolated robotic mitral operations, mitral valve repair operations. And basically, they included mostly neocord implantation. And secondly, there was resections, triangular or quadrangular. And also, 1 patient received edge-to-edge repair, and also 7 patients received annular reduction intervention. And next, please. And in these figures, we try to identify the period of the learning curve by the duration of the operation. And we had 2 parameters for this identification. The first one was the cross-clamp time, and the second was the cardiopulmonary bypass time. Also, one can include the total operation time for this kind of investigation. And we find out that after 30 cases in each for cross-clamp time and cardiopulmonary bypass time, the parameters were measured in means of decreasing. And for the cross-clamp time, it came down from 200 minutes to the 118 minutes. And in the cardiopulmonary bypass time, we observed a similar shift after the 30 case. And the next slide, please. So this achievement was gained because there was some kind of experience before launching and robotic mitral operations, because I know that 30 operation is not so much. We have some other data from other centers stating that hundreds of patients may be needed for the early period of the training for robotic operations. But there may be an exception for our clinic, because we had a previous mitral valve repair without robot experience. And also we had a minimally invasive setup experience and also transcatheter interventions experience. So I think these both parameters are very, very important for starting up an robotic mitral program. And also I believe that simulation training, case observations, and proctored cases with experienced surgeons like the panel here will be very helpful for such a launch of a surgical program. And also, it's very important that you have to be sure about the T guidance during the operation. You should have a very experienced anesthesiologist or a cardiac surgeon inside the room during the operation. And also, I would like to recommend the centers that in the early periods, we did the same. We just made a copy-paste performing of the very, very experienced centers. And this was about the during the whole learning curve period. And I think that this will decrease the early postoperative complications in launching such a program. And next, please. And I would like to state out some brief information about our current practice. Currently, we just use percutaneous cannulation with probe lights and just direct cannulation of the veins. And XX small axis for the soft tissue retractor is used during the operation. And also for the redo operations for the mitrals, we just perform the operation without cross-clamping. The cardiopulmonary bypass and hypothermia is just our classical setup. And we use triple clamp with a temporary cardioplegia needle for the cardioplegia. We used to use the custodial, but switched to modified del nido cardioplegia for several years. And routinely, I can say that the CT is not a routine. We just try to perform that CT for the very high-risk patients. We try to use more and more the ultrasound guidance during the operation, both for epiaortic ultrasound and also the T guidance. And we try to use the routine techniques for the mitral valve operations. We don't just try to switch from one technique to another technique. It's a little settled for now. And we have also a strict blood management, which I believe that it's very important for the success of such a program. And thank you for your time. And I would be very happy if there's a question for discussion.
Thank you, Dr. Sane. So we'll begin the discussion. Dr. Mick, what are your thoughts on beginning a new robotic cardiac surgery program without sacrificing patient outcomes. I imagine there will be an element of learning curve, possibly type of case selection that you keep in mind. Also, some level of component practice that we have to consider. What are your thoughts on successfully starting a robotic cardiac surgery program?
Thank you for the question. I was thinking as I was listening to the talks that it's interesting how different the learning curve is now relative to the learning curves that we described at the Cleveland Clinic, back in the earlier days, where the learning curve wasn't even just the learning of the team, but also trying to understand and create the operation at the same, in the very early days. So the learning curve there was more like 200 cases. And I don't think it's unreasonable that the learning curve now is so much shorter based on the collective experience that's come before. You can't really compare what was happening back then to what's happening now, where you have proctors, you have standardized protocols that many people are doing. And so those are just some of my thoughts on those, on the papers that we just saw. But I think my thoughts are really that it's very critically important for people to understand there are many different learning curves happening when you're starting a newer program. My learning curve is different than my nurse's learning curve and the guy who's assisting me at the table, his learning curve. So there's a collective learning curve as well. And so when you're starting a program or where you're coming from a very high volume center to a lower volume center and trying to start something up there, or really rather continue what was started by my predecessor, Sloan, what's needed is really a lot of training of the team when you come in with a lot of experience yourself. And having practice run-throughs. I made a lot of videos before I came to accelerate the learning curve of the team. And then, like you intimated, when you're starting a new place, even if you yourself have done very complicated things, your team may not be able to handle that. So I think case selection, as you suggested, is critical. You want to start with normal body habitus individuals with straightforward pathologies, no curveballs at the beginning, just to make sure everybody is up to speed. So those are some of my preliminary thoughts.
Thank you. Excellent point. Sloan, give me your point of view. Give us your point of view. You have an incredible curriculum in robotic, and particularly you have started 4 robotic programs. You have been involved in robotics since you were a fellow in 2002. Give us some ideas, and I like a lot of this concept of Stephanie about it's probably true that right now a training curve is different respect of the training that all of you experts, Dr. Balki, Stephanie Meek, you yourself have done in the past. So what are your 2 cents in this?
Yes, thank you, Gianluca, and thanks for the invitation to be here. And thank you, Stephanie, for those excellent remarks. I particularly like the comment about there are multiple different learning curves going on, the bedside assist, the nurse, et cetera. There's advantages and disadvantages to having started 4 robotic programs, and in addition, being part of Doug Murphy's program, one of the most mature in the world. And that is that one of the advantages is that you learn a lot of great lessons. And probably the biggest lesson that I've learned is that the environment really matters. And what I've talked about in the past is sort of a play off of the movie The Godfather, where you need the support of what I call the heads of the 5 families. So nursing, administration, surgery, perfusion, and anesthesia. And you really need support. The team, not just you, but the team needs support from outside the room. And really it needs to be continuous. And at any given time, if you do not have support from one of those 5, real support, not just support in words, but tangible actions, then you're gonna struggle. The second component would be what I call prerequisites, which would be that you have the volume to get started. Now, the first robotic program I started was at the VA San Francisco, and quite honestly, we did not have a lot of volume, and that really made a struggle, because you really need to do 1 to 2 of these a week in order for you and the team to get competent. And I cannot emphasize enough that this is not just a surgeon's operation. This is a team operation. I at one point made a somewhat famous or infamous comment that Doug Murphy could probably come to the San Francisco VA and not do a robotic mitral, but that I could go to St. Joe's and do one. And I pretty much proved that when I went and joined Doug. But because the milieu matters. So the milieu matters, the prerequisite volume and experience matter, whether you have right chest experience, how many mitrals you're doing, how many mitrals you have access to. And then the last is sort of the surgeon's skill set themselves. And I sort of rank them in a particular order about what's most important. And number 1 is team leadership. And I think that is the hardest. And I'm still learning lessons about leading the team. But I think that is one of the reasons why younger surgeons struggle with this operation, because you've got to be able to lead, command, and gain the respect of your team. And I mean an entire team about the size of a football team. It's a pretty big team. And that can be hard to do, particularly when you're new out of training. The second skill set I would say is what I call circulatory management. The ability to cannulate peripherally, whether you use the endoballoon, a cross clamp, et cetera. It's more difficult than it is to do a sternotomy and cannulation. The third skill set I would say is mitral valve repair. And when I trained at Penn, I was trained in traditional Carpentier techniques, which I thought the simplest operation we did was mitral repair. Give me a total arch, 3rd time redo. That's a real operation. Right until I faced my first mitral valve repair, and I cut too much posterior leaflet out and ended up with severe MR and had to replace that valve. And that was a very humbling experience. But what it taught me is that mitral repair is not as easy as it seems. And I think if you don't really know how to repair the mitral valve, and you get there robotically, and you go through all the 5 families support you, you have all this, and then you get to the valve and you don't know how to repair the valve, you're going to really struggle, because that alone is a hard skill set. The next skill set would be how to operate the robot itself. Now, there's really no excuse for not learning how to operate the system, because they have great simulation systems available. You can go for training with Intuitive. I think the best example of this is when Joe Durrani took over the program at Mayo Clinic. He every night after a long, busy surgical schedule, he would go and work on the simulator for a couple of hours. And as a result, he got quite facile with it. But people don't want to do that. They don't want to spend the time. We've struggled as we've tried to get programs launched across the country through the STS with people not wanting to do simulation exercises. It's pretty easy to use the robot. I've run courses for little kids, like, 4th graders. And believe it or not, I had my son when he was about 8 years old do a robotic mitral and pig heart quite well. So it can be done, but you've got to do it. You've got to sit down at the console and do it. And then the last skill set I would call sort of administrative functions. These type of operations require a lot of toys and gadgets. And those gadgets have serial numbers, they have catalog numbers, they have companies you have got to get them for, they have a price tag. So you have to have administrative skills to be able to accumulate that material in the operating room in a timely fashion, while training your team, while getting yourself ready to go, et cetera. And it can be difficult. And I think there are times to look at an environment and say, hey, this is probably not the place to start a robotic program for one reason or another. And that's a very hard thing for a young surgeon to do when they're eager to try something new.
Thank you, Dr. Guy. That was a very detailed description of all the components and possibilities that a new program a surgeon can encounter. Dr. Balki, what are your thoughts on the learning curve of robotic coronary surgery? Do you think a lot of the points Dr. Guy mentioned carry over specifically to robotic coronary surgery, and what is your experience?
Sam, you're muted. If you can unmute, I'll find you. I unmute you.
Sorry. Yeah, I
Yeah,
apologize. Thanks, Irbaz, for that question, and thanks to Gianluca and Professor Salerno for hosting this morning session. I agree with everything that's been said with Stephanie and Sloan's comments on some of the deeper points of the progression of it. I think there's a couple of different issues here that we're kind of looking to discuss given the two papers that were presented. One is, how do you train a junior person in robotic cardiac surgery? And the other one is how to start a program in an established cardiac center successfully. And I think those two things, as similar as they are, might be a little different, and they're changing. And I think the comments that Stephanie made in terms of the difference between now and what we were doing in the past, you know, I did my first robotic procedure as a full-fledged 10-year out, you know, attending in private practice at 3 different hospitals in Milwaukee. And that was in 2006. And I did it after a half-of-a-day course at Hackensack University in the cadaver lab with one of the intuitive reps who said, here's a cadaver, take down both mammaries. And I did that, and then I went home and basically said to my patient, I can do this. And, you know, and I think that's the curve that Will's study shows. It shows the first 10 cases are different than the second 10 cases and the second 100 cases. The life is different now. Now we have residents coming out of training, having had experience doing robotic surgery on the abdomen. There's many residents that have done thoracic rotations. And so the system itself is not foreign, and it's not a, you know, a novelty. What then remains to be done is to talk about the things that Sloan said, which is, how do you put that experience that the residents are coming out with now with some hardcore organizational skills and knowledge of cardiac surgery? And we've always struggled in our specialty as to when is the best time to take somebody to go from being a cardiac surgeon who is newly trained, or a cardiac surgeon in the middle of training, or a cardiac surgeon who is 3 or 4 years out, and make them a successful robotic surgeon. And I think that most people would agree that you need to know how to do cardiac surgery first. You need to know it well. You need to know how to get yourself out of trouble, and you need to know all the different nuances of the procedures that you want to translate now to the robot. So I will say that learning how to do mitral valve surgery after you started to learn robotics is not the way to go. You have to master the mitral valve in the usual format. Now, things are changing, and people who spend time in a program that does robotic mitral surgery already will come out with the knowledge of the mitral valve through the robotic approach. And that's good. It's like learning a new language. You don't have to translate it from one term to the other. You just learn that term. So if you want to learn French, you learn the French word for, you know, a cup, and that's what you know. It's not a translation. And so I think that there is something to be said for understanding the anatomy and understanding the approach through the robotic system a priori. And I think that's what a lot of the general surgeons are doing with laparoscopic cholecystectomy and whatnot. And I think there might be some criticisms of that as well as to the bailouts and what you can do if you get into trouble and things like that. But in terms of the applicability, Irbaz, which is your question, of coronary surgery to the mitral stipulations and considerations that Sloan was talking about, I think they're pretty reproducible. I think coronary surgery is fast becoming a specialty, and you know, Gianluca and I have had rounds and rounds of conversation about whether or not that is appropriate. We both think that it is, and robotic coronary surgery is one of the features of a subspecialty called coronary surgery, and I think that having the team and all the different facets of what Dr. Guy was talking about is as important in robotic coronary surgery as it is in robotic mitral surgery. I have a little bit of a radical view on things, and I am somebody who believes that the robot is merely an instrument. And if you are a heart surgeon who does valve surgery and does coronary surgery, why, you can double your learning curve rate by doing everything with the robot. And that's what we do. We do pretty much all the procedures that I do are done with the robot. And I think that's the best way to success, because in the end, what you're doing is you're using an instrument to do the surgeries that you already know how to do.
Excellent point, Sam, as always. And this is an incredible form of information. I want to engage Dr. Matthew Williams. I was very, I read with a lot of interest your paper on the STS database and learning curve about robotic coronary. And I just want to ask you where this paper comes from. As for my understanding, you don't perform robotic coronaries, but I was very curious to know what was your first and original question. I'm always fascinated by people that looks or are interested in understanding better the robotic world.
The origin of the paper was that, to try to center a patient in the discussion around robotic heart surgery, that a learning curve is a very abstract term, and what a learning curve means for the group of patients who are those first patients that are operated on is, can be a very serious matter. And I was hoping to find that it was a short learning curve, that there was an inflection point that we could see where outcomes stabilized, and I wanted to better inform the community, and that means individual surgeons who are thinking of embarking on robotic heart surgery, how long they should be closely mentored. It's about gatekeepers, hospital administrators who are deciding who can and can't have those kind of privileges, what sort of experience they need to have so that it can be made safe. The learning curve can be as safe as possible for our patients.
That's a great point, and thank you. I found that very interesting, the fact that, and this goes exactly with what Sam Balke was saying, and we have also Thomas Salerno, one of the father of off-pump. At the end, robotic coronary, you first need, as Dr. Sam Balke, as Sam was saying, we need first to know heart surgery. And in robotic coronaries, you need to know off-pump and to be expert in multi-arterial and in off-pump technique before you can embrace the idea of performing via small thoracotomy, or even better, total endoscopic robotic a bypass. And I think that one of the struggles that heart surgeons have faced in adopting robotic is exactly this one, is the fact that you have to pass through a new learning curve that is learning the robot, is learning those soft skills that Sloan and Stephanie Meek were talking about in a moment after you have already finished your training. Your training is very, very long, and you say, you know what, just forget about it. I do a big incision and I keep doing what I've already done. Why try to learn something new at a certain age and a certain point? But we are clearly facing a different moment. So Sloan, give us a little bit of understanding in your point of view, why a young resident right now should, in an era where everything is transcatheter, in an era where everything is going in a different direction, why a young resident, why William Patrick, that is a UPenn I6 resident, why he should be interested in robotic, when he should start to be interested in robotic? Right now, in 10 years, what is your elevator pitch to him to tell him training robotic? Goes loud.
I think that's a great question. A lot of it has to do with sort of the history of our specialty. And I think that if you look between 1950 and about 1980, there was a period of incredible innovation that occurred. And then from 1980 to, arguably around 2000, between 1995 and 2000, there was a period of maturation where people basically did not do a lot of things new, and but they tried to perfect the clinical results of what we already had. And then now what's happening is there's new technology. You know, aortic valve replacements were a big part of my practice 10 years ago. Now less so because of TAVR, appropriately because it's better for patients. Cardiac surgery does not exist for surgeons or hospitals. It exists for patients. And if it's better, then that's better for them. But if you really look at our specialty compared to other specialties, and this is a hard pill to swallow for cardiothoracic surgeons, I would say that we are not nearly as innovative as, say, OBGYN or urology when it comes to embracing the fact that patients want minimally invasive. Yes, it's hard. Yes, there's a learning curve. Yes, there's new techniques that need to be developed. But our predecessors who developed basic open heart surgery did all that for us and handed those skill sets to us. And what we now call conservative, old-fashioned heart surgery was at one time just as hard, just as cutting edge, just as challenging as robotics. So now I think if young people do not embrace this, they're really going to find themselves on the sidelines of where cardiac care is going. You know, sure, transcatheter is very sexy and great, and I think there will be cardiac surgeons who continue to do that as primary operators. However, some in Las Vegas would probably not bet the farm on that, right? They would say that more than likely those procedures will be dominated by interventional cardiology, just based on the realities of the world politically. And so this is the path less traveled, there's no doubt. But my prediction is that robotics will be a major part of our specialty in the next 20 or 20 years as the old guard, the baby boomer surgeons who were very conservative and frankly, often were not very supportive of younger people doing new things. As they go away, as the competition becomes more and more fierce, I think that this will be a niche that will persist into the endovascular era. I also think that there will be emerging. Right now, we use all percutaneous cannulation under fluoroscopy, for instance. I would imagine 20 years from now, a robotic mitral valve repair will probably be done with robotic catheters, robotically controlled catheters with forward-facing 3D echo or what have you. So I think this is a good subspecialty to get into. It's particularly challenging right now, but it can be done.
Thank you, Dr. Guy. Dr. Mick, in your operating room, when you have a fellow that you're training, or let's say an I6 resident, what is their role with you usually when you're trying to teach them robotic surgery? How do you escalate their role? The second part of my question is cardiac surgery training or cardiothoracic training is relatively short, 3 years. How can a fellow or a resident accomplish learning some level of robotic surgery in this time, along with all the other things they have to learn?
Thank you for those questions. So I think that my teaching of the residents is kind of like any other case, any other cardiac case. It's a graded exposure and graded level of more and more intense involvement in the case. So at the beginning, they're learning. So I have them watch some videos and read papers so that they understand the flow of the operation. And then they help with the cannulation initially, and then they can't help with the placing of the ports and getting the setup, putting the pericardial stitches in and so forth. And then at the beginning, a lot of it is just watching me do the mitral valve repair, because frankly, many residents haven't even really seen a mitral valve until they've really seen it, themselves, until they've seen it robotically, just because of the visualization, So they'll watch that, and then the next step will be to have them help me close the atrium. And then the next step will be helping with the annuloplasty. The very, very last area that they're allowed to do is any leaflet work, obviously, because that has the highest potential for issues if it's done improperly. But it's just like any other surgical training. It's graded response, graded, involvement in the case. At the beginning, it's nice to look together with the robot and talk about the valve analysis. I think a lot of the learning in a robotic case for residents it's funny because it's true, you can't do robotic mitral valve surgery until you've done a lot of open surgery, but I do believe residents' open valve performance is positively affected by it being involved in robotic cases, precisely because of the visualization, and you can really understand what's happening there better than if you're peeking across your attending's shoulder, or even better than if they have a little camera set up there. I think that's really helpful. And your second question is, what should you do if you're an I6 resident and interested in robotic cardiac surgery? It's true, there's a lot of challenges there because you're learning the primary skills rather than the advanced, in addition to the advanced skills. So I think the best thing to do is, if you're at a place where people are doing robotic surgery, to be involved in those cases, be involved in the non-robotic minimally invasive cases, and also be quite involved in the interventional cardiology side of things and the structural heart as well, to learn those catheter skills, just as Sloan was saying, to facilitate your minimally invasive experience overall. I mean, do you need a fellowship? Do you need another year of advanced training to be able to really confidently be able to do robotic surgery? I mean, I'm a little biased in that that's what I did. So I do believe that dedicated time is required to really, really perfect it. Maybe I think it helps with the maturation. And just as Sloan was saying, if you're going to be trying to go somewhere and introduce something new, you have to have quite a lot of experience behind you to gather the confidence of your team and to be able to pilot through any challenges. So particularly for somebody who's wanting to go and maybe even start their own program, I would say another year of fellowship would be pretty important.
Gianluca, can I engage Matt and Will just on the paper? I was very intrigued by the methodology, Matt, of the outcomes that you were looking at, and I had a question about whether or not you were thinking of doing this for robotic mitral procedures as well, because I think there's a lot to be learned there. And it was very also interesting for me to see that the successful procedural outcome definition, which is basically finishing the procedure and having no major morbidity or mortality, was achieved before the efficacy of the procedure was achieved in most surgeons' hands, i.e. it took longer to take the mammary down, but it was a successful operation. And so when you gauge it as that, then you get into 10 cases. Whereas when you talk about time and speed, which is what everybody kind of looks at when they're assessing these things, it seems that it took more, a higher number of procedures. Can you speak to that a little bit? Because the statistical methodology was very, very interesting and quite advanced, I thought.
Sure. Thanks for the question. I think that, again, taking a patient-centered approach, I don't think patients care whether it takes a half an hour or 45 minutes to take down a mammary, as long as they have a nice open limit LAD at the end of the operation and they're intact, a month from the operation. So it's a patient specific kind of definition of success. In terms of the statistical analysis, I mean, yeah, there were a lot of complicated statistics the DCRI employed, but I think that the major thrust of the of the statistical analysis is quite comprehensible, and frankly, no great surprise that when people do more robotic cases, they have more success clinically. I mean, it's not too complicated. I was really curious as to when that transition from rapidly improving patient outcomes to stable patient outcomes occurred. And that's what some of the statistical analysis was able to put math around. You can look at the curve and say, well, it looks a lot flatter here. The results must be stabilizing, but there's some mathematical analysis that supports that very sort of intuitive, no pun intended, interpretation of the analysis.
Any plans to do it on the mitral side?
Oh, there's quite a long queue at the SDS for any kind of mitral papers, so I think somebody else will have to write that one.
Dr. Bach, I think your point about the differences in the learning curves between the component-specific tasks and the clinical outcomes is actually a really fine one, and something that I noticed as well. And the conclusion I had made was that probably surgeons are getting safer before they're getting faster, which I think is comforting.
Yeah, and I think patient-centered is the way to look at this, because when a patient comes to me and says, I want you to operate on my heart, I could either slash their chest open and do it in 3 hours, or I could take my time and do a totally endoscopic multi-vessel all arterial graft procedure in 5 hours, and they will be happier because I took my time and I didn't necessarily do 3 cases that day, and I didn't bring the hospital a whole lot of money that day, but I took care of their heart. And that's what your paper shows, is that speed is not what the success means. The efficacy of the outcome is what success is, patient-centered.
I think it's worth mentioning on the coronary side how I learned how to do coronaries, even though it's not my primary focus. What I did was I took standard multi-vessel coronary bypass patients, and I got them to agree to let me put the 3 robotic arms in. At the time, I think I was using the S system, and take down the mammary, and then do a sternotomy. And that took the pressure off to a large degree. And I was surprised how many patients were willing to do that when I explained to them what we were doing. And essentially what I did was I said, I'm going to give myself 1 hour to take down that mammary. And at the end of an hour, I'm going to stop, do a sternotomy, and get the case done. And that way the team won't get too frustrated. The patient will be safe, and my learning curve will be limited to really impacting me with the addition of 2 or 3 extra holes in the patient. And so I'm embarrassed to say, and I'm sure Sam, I can't believe you did a 2 IMA takedown your first case, because that is so far beyond my skill level. I took down 1 inch of a mammary on my first case or 2. And I remember Joe Wu came out and proctored me. And, it was a great success that we had done a robotic case, even though I literally took down 1 inch on each case. And it took me about 20 cases, and I'm not a slow surgeon, but it took me about 20 cases to take down the IMA in a reasonable time frame between 45 minutes and an hour. And then I progressed to doing a thoracotomy and a robotic assisted midcap. And I think that's a really, really nice way to do it if you can get, the support of the patient and your leadership to do that.
Yeah.
Excellent. Sahin, I want to engage you because your paper about training and the experience of your center in the mitral is very, very important. I think that shows that you can safely perform this surgery. It's a team approach, can be done appropriately. And in agreement with everything we have said today, it's not really a matter of time, but it's a matter of offering an incredible advantage that is the results of a mitral valve repair in a complete closed chest. And this is outstanding. So tell us a little bit more about you. At which stage did you start to get used to or to get involved with robotic together with Dr. Jem? How does the program works? Where do you stand in the robotic? Do you cannulate? Do you stay on the table side?
Yeah.
Give me a little bit of
I guess one point is very important because Dr. Miki has pointed out that there are some differences between the centers and there are some time gaps between the centers which practice the robotic cardiac surgery. First of all, we have been proctored by very experienced surgeons like Dr. Chitlu's team. We have observed the team in Mayo Clinic at the early stage. So I guess the difference may come from these parameters. And there was a huge preclinical training issues in our center, including the simulation programs and the cadaver trainings, and also, as I said before, the proctored cases. And after that, they came to a stable robotic operation in means of time, OR time, cardiopulmonary bypass time, and cross-clamp time. Currently, it's about 1 hour for a isolated mitral valve repair in means of cross-clamping time, and about maybe 70 or 80 minutes in means of cardiopulmonary bypass time. Two surgeons perform each step together. It can be a thoracotomy or the port implantation or the groin cannulation, me or Dr. Jem. And also, both of us are capable of doing the console things during the operation. But the team is single. I mean, from the beginning and until now, our nurse is the same. The perfusionist is the same. I mean, the anesthesiologist is the same, and we are doing this job as a whole. I think it comes from these aspects. I mean, this is a single center and single team experience, so that might be the reason for the shortage of the learning curve period for the robotic mitrals.
I don't think it can be overstated the importance of two surgeons on a learning curve as opposed to one surgeon doing it as a learning curve. I mean, I think that's a really important point. I mean, things are vastly different when it's just you. I've experienced both systems. You know, at the Cleveland Clinic, we were doing it as a two-surgeon case. And now here at New York Presbyterian, it's a one-surgeon case. And there's a whole number of different ways that even just the presence of another person can smooth things along or speed things up in ways you may not be able to delineate. But I think that's a pretty fascinating aspect of it. And I think that I don't remember seeing that in the manuscript, but I think that's critical in terms of the success of this, your particular great success of your program.
And I guess it's more safe in terms of the patient aspect.
Absolutely. One of the other elements that I want to highlight, and I think is one of the most important skill that I learned during my time with Sam at University of Chicago, are the soft skills that even Sloan was mentioning at the early beginning of this conversation, and leadership skills that you need to have to accomplish this type of surgery. You need to drive the entire team calmly to the next step. And sometimes if your final goal of the day is to put just 3 or 4 cases done for that day, it's extremely complicated. You need to change your mindset. So Sam, tell us, how do you train yourself, or what are the suggestions you give to the surgeons out there that have been trained to be like the best cardiothoracic surgeons? Means you have to do 6 cases in a day by 5 p.m. and at 6 be on the golf yard shooting something or reducing your handicap. How do you change this mindset into the idea, take your time, be nice with everybody, make sure that everybody is at the same point and progress nicely? What are your 2 or 3 tips in this sense?
Well, I think it's what we have always strived to do as physicians, and then as surgeons, and then as heart surgeons, which is do what is best for the patient. And it could be best for the patient for you to take a saw and cut their chest in half, but it also could be best for you not to do that. And if you want to specialize in doing heart surgery without using the saw, then it's a dedication. And train yourself how to do it very well. If you're a young surgeon, you want to approach this, train yourself how to do it very well, and look your patient in the eye and tell them that you're going to do the best job for them. That's why I really, really like this paper that Will discussed, talking about patient-centric outcomes and not hospital-centric and operating room-centric outcomes. It's all about the patient. And there's a lot of psychology, there's a lot of depression that goes along with sternotomy. And if you kind of internalize the benefits of sparing the sternum, and then you realize that you can do that with the current technology, then you develop the mindset that says, we're going to do this and we're going to achieve it together as a team. And it increases your level of patience with things that might be, kind of not going your way directly, and you kind of just continue to work at it. And it's a mindset of patience, really. People say, well, how can you do all these TCABs, multivessel, da 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 da? I think it's a matter of just keeping your eye on the prize and continuing to look at the final goal as to what you want to achieve. I just saw a message from Professor Salerno saying that people can do the same thing with small incisions, but they can't do it on everybody, and they can't do it on people who, yeah, they can't do it with 8 millimeters, that's for sure, but they also can't do it on obese people with small incisions. They can't do it on redos. They can't do it on frail people. And those are the people that benefit from sparing their sternum. So if your goal is really to help the people that have come to us to fix their hearts, then you will have the mindset that says, I'm going to do it in the people that really, really benefit. We did a guy with a BMI of 49 the other day with 2 IMAs and 3 bypasses. And that patient would never have gotten bilateral IMAs in a sternotomy setting. So I think, Gianluca, you speak of the soft skills, which is basically patience, and then surgical skill is achievable with just a lot of time at the console, a lot of time at the simulator. I think that is quite secondary. The other thing I would say, you said 2 or 3 points. The other thing I'd say would be engaging the team and empowering them to kind of do their own thing and take charge of their part of the operation. Sloan probably can speak to this. When we're using the endo balloon, everybody has agency to say that the right radial pressure is dropping, and everybody has agency. We have these Bluetooth headsets that now Sloan is using as well, and they're very, very effective. So I think those are a couple of little pearls on that regard.
Thank you, Dr. Balke. Dr. Guy, I have a question about the future of robotic cardiac surgery. Would you anticipate this would be, let's say, 5-10 years when we become attendings? To be more specific, do we still have industry support for developing robotic cardiac surgery, considering all the innovations coming from interventional cardiology in terms of transcatheter mitral interventions? How do you foresee this field evolving?
Well, I think it's going to grow because of programs like yours. I think a lot of new programs are starting. The Robotic Task Force for the STS, of which Sam, Gianluca, and Stephanie have been participating in, has been really trying to support new programs. I think the more programs that open, the more we will get industry support. There's no doubt that one of the elephants in the room has been lack of industry support. For instance, in Europe, Intuitive has decided to not be supportive of robotic cardiac surgery due to changes in regulatory rules in Europe towards cardiac procedures. Intuitive stopped making the coronary stabilizer. So there are some real challenges, but one of the most valuable times of my life was the 4 years I spent in Silicon Valley, and I adopted that mindset of innovation. And I think that the patient's demands for less invasive procedures will increase. But I also think it's going to need to be truly minimally invasive, completely endoscopic patients. The patient that I did on Thursday was a redo robotic mitral valve repair. Could have gone home yesterday, but had a small air leak. Will be going home this morning, has no air leak. That's not possible if you're doing a big thoracotomy. And so I think that the field will evolve, but you will have to make it evolve and grow.
Earbuds, I want to take the ball here, 2 minutes. And this sounds, as a young surgeon, I've been asked a lot of time why I'm so enthusiastic about robotic, why I'm not instead way more interested in transcatheter or new technology. Something that I do, I perform, I engage myself into, but is not my primary focus. The reality is that when you look at what transcatheter are doing, are a great tool. It's probably one of the best invention of the last 20 years in the cardiovascular world. But still, there is a huge compromise for patients. It's true for AVR even. TAVR, for how much a propensity match or a randomized trial want to show you, still gives you way more pacemaker implantation or way more question mark about durability than a surgical AVR. And Robo is really the only platform that allows you to achieve a phenomenal results that has been proven, like in mitral valve, for 20 plus years of excellent outcomes to a patient, or can offer you the benefit of multi-arterial bypass grafting, the opportunity to offer 2 mammary artery to the best target of your left coronary system in all comers. It doesn't, and this is something that a thoracotomy does not allow you. That's particularly true in coronaries. When you look papers, even from my dear friends Piros Daviervala in multi-arterial bypass, I think that what he does through a thoracotomy is phenomenal. But at the end, when you look the selection criteria for those patients is very, very, very strict. You can't do a high obese patients in the 50s with a BMI of 45 and offer him 2 mammary arteries via a thoracotomy. And this is something that instead I've witnessed myself being possible to perform. And I've done it myself in last week on a BMI 42, 2 mammary arteries. So this is the mindset, is quality more than quantity. Is quality for your patients, quality in the repair, quality in the multi-arterial revascularization. That's what the Robo can offer, and that's what the Robo gives you. I want to start to wrap up this conversation, and I want to involve Dr. Thomas Salerno, one of editor-in-chief of Journal of Cardiac Surgery, but also one of the father of off-pump coronaries. So training in cardiac thoracic surgery has always been a very important topic. Somehow, and I say it loud, training a young cardiothoracic surgeon is one of the most difficult tasks because of the complexity of what we do. And independently from a sternotomy of a robotics, there's nothing to say that cardiac surgery is difficult, it's challenging. So what are your give us some wise words about training training cardiothoracic surgeons, training the new generation, and engaging a new generation of cardiothoracic surgery for robotics. Thomas, what do you think? You are muted. If you want to unmute yourself. Here we are.
First of all, this is an incredible lecture by pioneers in this field. I very much appreciate your presentation. They're crisp, clear. I think those listening to your presentation become more and more interested in robotic surgery. One of the questions that someone always asks me, how is it that I went from being on pump to off pump? After listening to Bennett and Calafiore and Benio Buffalo, I decided that the heart-lung machine was not part of this operation. And from one day to the other, I decided that I'm not going to use the heart-lung machine in coronary artery surgery. So like you, when someone asks me, what are the indications for off pump? Well, it's coronary artery disease. Doesn't matter what it is. I don't find the heart-lung machine is needed except it's a bailout procedure. But I think your presentation today has been really inspiring to me of an area that has been not fully explored. As you know, I was old enough to remember the robotic controversy with Chitwood when he came about the mitral repair, etc. It's a tool, and it's a real shame that we're not utilizing this tool to its fullest potential, because, as you mentioned, visualization is incredibly better than through big incisions, and the benefit to patient is incredible. The only concern I have is to call this minimally invasive. This is not a minimally invasive operation. It's a small incision with tremendous benefit for the patients. Invasiveness is the use of the heart-lung machine. And when you think about all the procedures developed by the cardiologists, from MitraClip, TAVR, Neocorda, it's all related to elimination of the heart-lung machine. Robotic surgery has been an incredible advancement in cardiac surgery. I want to congratulate you all for being leaders in this field. And I think, Gianluca, it's time for you to have a special issue for the journal on this topic and invite them all to write a paper on this. We're very grateful for all of you for your participation. Many thanks.
Thank you. And with these words, I think that we can winding up this live talk of this Saturday morning. As you know, it will stay on YouTube, and please subscribe our channel to know our next topic of the next live talk. Again, if you want to be part of it, just submit your best paper to Journal of Cardiac Surgery, and we will select you and your most senior author to come up here on a Saturday morning and have a coffee with us. I want to thank you personally, all of you, everyone who participated today. Really grateful for your time on a Saturday morning, and hope to see you soon on a next meeting when COVID will permit finally to start to shake our hands and see each other in live. Thank you again, and this was a great time. Bye. Thank you.